Thank you. Thank you for inviting me for this conference, just giving me the opportunity to talk a little bit about pituitary neoplastic lesions, basically the invasive, atypical, and the aggressive pituitary tumors and the pituitary carcinomas that as a team, Fabio, Dr. Ciro, Antonio, and Dr. Cusimana, and our director, Dr. Kalman Kovac from the University of Toronto, so Michael's Hospital is the director of this paper, that we already published this paper. Something wrong, it doesn't. I think this is much better, yeah. Okay. We have just published this presentation at the beginning of this year in the Endocrinology Metabolism of the Clinics of North America. My topic will be just as the outline. I will just give you a brief information about how we classify the system, what is the recent classification by the WHO in year 2004, and what is an atypical adenoma, an invasive adenoma, aggressive adenoma, and what are the most likely used biomarkers and the biomarker research in that field, and the pituitary carcinoma. So I will just try to exclude the definition of the pituitary adenomas, which is consisted of 15 different adenoma types according to their ability to secrete and manufacture the specific proteins. I will concentrate on the these basic atypical adenomas, invasive, and the aggressive adenomas, which is a little bit confusing because since the time of the WHO's classification, we don't have a specific designation called as the aggressive adenoma, but in the market, if ever you just put your hand on the computer and try to find out the research on the internet, then you will be seeing that a lot of aggressive adenomas, what are they, and so how they should be defined as. As you can see, the pituitary is a small organ that is being located just in the cella, and it has a close communication and close neighborhood with the cranial nerves. And up in the end, you can see it has a close correlation with the optic chiasm, and down in the sphenoid sinus, as well as on bilateral units, it has the carotid sinuses. So these are the important facts for the neurosurgeons while removing a pituitary adenoma. Whether as if it is an invasive adenoma, it might be sometimes just complicating the issue. The pituitary adenomas as a whole, if you just look at their relative frequency, they are just after the meningiomas, glial tumors, and metastases. They rank in the 4th place, just form almost the 10 to 15% of the pituitary neoplastic proliferations. That includes adenomas and the ones that I have already mentioned. And again, they are accepted as benign lesions. There is a small part that show an aggressive clinical behavior that forms almost 2 to 5% of pituitary neoplastic proliferation that involves the invasive and the aggressive adenomas and the atypical adenomas. Now, this is the definitions of the pituitary. These are the main definitions, which is talked about the pituitary adenoma properties. We either just use the morphometric criteria, whether this is more than 10 millimeters in diameter, that should be called as a macro. If it is less than 10 millimeters in length, this is called as the microadenoma. And in the case of the giant adenoma, that might go up to reach 30 to 40 millimeters. And so the volume is excessive than the 10 cubic centimeters. In the case of the invasiveness, we can be just talking about how invasive the tumors, the surrounding the structures that are already shown in the cartoon before, that they have a close correlation between the 3rd, 5th, 6th nerves, as well as the sinuses, cavernous sinuses, and up in the end, there is the optic chiasm. So this is important how invasive they are from the particular point of their ability to invade. Almost 50% of the cases are invasive in terms of the microscopic examination. The other point is that supracellular extension of any tumor is not a criterion of the invasiveness. And on the other hand, we have the radiological classification, which has been defined either by the Hardy or the KNOSP, that shows how extensive the invasion of a tumor. And in generally, the macroadenomas can be invasive, but they are not clinically aggressive. This is another fact to be kept in mind. From the point of their aggressiveness, we in generally take their behavior in the clinical sense. We don't have a defined percentage of how often do we see the aggressive tumors. And the other thing is we just look at their mitotic activity plus the Ki-67 labeling indices as well as the p53 immunoreactivity while defining their aggressivity. There are some specific histotypes that, for example, the small ACTH adenomas just act more aggressive than the tumors, which has the ability to synthesize and release the other group of the endocrine, the markers. And although non-metastatic, some tumors are just show some features of the atypical adenomas. The invasion of the surrounding tissues by the pituitary neoplastic lesions in general complicates the complete resection, and that is an important cause for the postoperative recurrence. Now, if we just look at the pituitary adenomas, how can we classify them? We can just looking at their morphologic and the features, they are divided as typical or atypical. And from the point of their radiological findings, they can be invasive or non-invasive, or clinically, they can be aggressive or non-aggressive. Again, in the literature, in the relevant literature, you can see that some of the authors are just using the aggressivity in terms of the invasive and the atypicality, which is a confusing fact that is not being covered by the WHO's 2004 classification. So we need some clear definitions to understand what's going on. This is the original paper or the book, the Blue Book, published by the WHO. As you can see, there is a very simple classification. The pituitary adenomas are just divided as typical adenomas or atypical adenomas and the pituitary carcinoma. That's it. But the things are a little more more complicated than it seemed to be under the microscope. According to WHO classification, the ones that I read, that's been shown in red, is being the original definition by this classification. In the typical adenoma, Ki-67 proliferative index should be less than 3%. There are infrequent mitosis or the monotonous histological feature, but that is not the case in all typical adenomas. In atypical adenomas, WHO says that just concentrate on the Ki-67 labeling index. If it is more than 3% and there is a nuclear setting for the tumor suppressor gene protein p53 should be extensive, call that lesion as an atypical adenoma. In the carcinoma cases, we need only one strict criteria, that is the craniosspinal dissemination and or systemic metastases, whatever the histopathologic feature is. In the case of the invasive adenomas, the adenomas has the ability to invade the surrounding tissues, such as the cavernous sinuses, bone, or the sphenoid sinuses, which have the close correlation with the surrounding structures. Also, as I mentioned in the Antonio's paper, that supracellular extension is not a criterion. The invasion can be spotted by using the MRI, or this can be spotted during the time of the surgery, or with histopathologic examination. It can be possible to demonstrate the presence of the spread to the dura, bone, or the nasal mucosa. MRI is the most commonly used the tool while diagnosing, and so far we have the 3 Tesla the MRIs. So it shows a very detailed anatomic structure, and the classifications, the radiological classifications offered by the NOSP in 1991 or the Hardy's grading systems are widely used while defining these invasion patterns. The one at the top is the Hardy's classification. This is the sphenoid sinuses and the optic chiasm and the sella. And lower the grade is, your tumor is just located within the intracellular area. And higher the grade is, you can see the extensive invasion of the surrounding tissue. And as the subtype of this grading Hardy's classification system, grade 3 and 4 shows the paracellular structures symmetrically or asymmetrically invaded by the adenoma or not. In the NOSPS classification, it is more or less the same. It's more simple to apply. Again, this grade, the 0 is the intracellular, whereas the grade 3 and 4 are the asymmetrical invasion of the neighborhood. In the case of the invasive adenomas, dural invasion by microscopy is not infrequent. So therefore, it is not regarded to be a consistent indicator of the aggressive tumor behavior. So in the case of the invasive adenomas, the cavernous sinus invasion is almost 1/3 of the cases. As expected, the macroadenomas have the more propensity to invade than that of the microadenomas. And dural invasion by microscopy is almost more than 75% of all cases. And again, the large adenomas are just much more invading the dural invasion than that of the adenomas with the smaller sizes. This is not an unexpected finding. So I have to mention about two papers, which is just, this one just written by the Özgür Mete from the University of Toronto, Sylvia Assa's team, and the aggressive pituitary adenomas diagnosis. Again, this is Antonio's recent paper that was published in last year to tell us what we have in our hand in terms of the aggressive adenoma. In order to call it a tumor as an aggressive adenoma, we need some parameters, which is made, the one is the multiple recurrences. The second one is they have to be resistant against the conventional therapy in terms of the medical and the endocrinologic therapy. They are either larger in size or faster in growth or both. The aggressive versus non-aggressive is, according to their clinical behavior, aggressive versus non-aggressive is, they do show a high rate of recurrence, they demand for the repeated surgeries, and they are resistant to the conventional treatments. And the classifications, between the classifications, there is not a consensus, and there is not a proportion. So on which classification should we demand on while calling a lesion as an aggressive or non-aggressive pituitary adenoma? The pathologic findings do not correlate with the radiological findings and clinical findings and the clinical behavior of the tumor. I would like to mention a little bit about the confusing facts. For example, some typical adenomas may have an aggressive clinical behavior. For example, although they do show at Ki-67 labeling index less than 3%, they do show a high rate of recurrence. They might resist to the medical or the surgical treatments. Another point is that in some atypical adenomas, they don't always follow an aggressive behavior. They can be invasive or non-invasive. So not all the invasive adenomas display a pathological features as we consider with the atypical adenomas, and their clinical behavior can be non-aggressive. So some non-invasive tumors may behave aggressively. So what shall we do? In terms of the pathological features, we just classify the adenomas as typical or non-typical, as the WHO 2004 forwards. Based upon the radiological and surgical findings, invasive and non-invasive are the two terms, and according to their clinical behavior, some do just act aggressively, whereas the others don't act aggressively. So when we just look at the relevant literature, the paper that's been written by the Catherine Trillo from Lyon, that she spends more than 40 years in that particular field, she offered why not just combining all these clinical and the radiological and the surgical findings with that of the morphological findings coming from the immunohistochemistry and the morphology and put them together and classify the aggressive adenomas accordingly, saying that Ki labeling index should be more than 1%, their mitotic activity should be more than 10 high power field, as well as they should be showing a widespread p53 expressivity. So in terms of the aggressive adenomas, some papers, some authors do say that there should be a cutoff level for the Ki-67 labeling index that is more than 10%. That is the Heney and his friends. And Pascual says that why not just using a little bit more higher index, say that 20 to 30% of the Ki at 67 index. And the same author says that the diagnosis is almost too late and is too little. And the very last paper, again, by Katrin Trullo in 2013 says we should be classifying the aggressive adenomas as a 2B, in where the 1A non-invasive, 1B is the non-invasive proliferative, 2A invasive, 2B invasive and proliferative, that is the aggressive adenoma, 3 is the metastatic, that is actually a pituitary carcinoma. So the questions that should be asked is, are the aggressive pituitary adenomas are unrecognized carcinoma? Or are they the pre-metastatic carcinomas of the cellular phase? Or are they the cellular in situ carcinomas? Or are they localized carcinomas? Or are they the tumors with the suspected of the malignancy? We don't know. That's a matter of terming how to mention about that. But we definitely know that there are some specific histotypes of the pituitary adenomas by using the conventional the histochemistry, in such that some should be supported by the electron microscopic features, such as the Krug cell adenomas. They act in 75% of the cases as aggressively. They invade the surrounding structures, and this should be a Krug adenoma. In the gonadotrope adenomas, as well as sparsely granulated somatotrope adenomas, and densely granulated lactotropes adenomas, acidophil stem adenomas, which is this kind of tumor that co-expresses the presence of the GH and the PRL within the same cell, and the thyrotrope adenomas, some pleurohormonal adenomas with a combination of the GH, PRL, and ACTH, and the TSH, and the glycoproteins, silent adenomas of ACTH silent, type 2, and the silent GH adenomas, somatotropinomas, and last, null cell adenomas. We know that these specific histotypes just show an aggressive clinical behavior than that of the classical pituitary adenomas. Again, one of the confusing facts is, although we do have a lot of information coming from the pathology, also from the ultrastructural findings and the molecular studies, we cannot be able to predict the aggressiveness and the tumor type of a tumor for the time being. That issue should be resolved. The next question is, Dr. Kovac, for about 5 years ago, just gave me a specific question, try to answer that, what has been done in the literature in terms of the potential biomarkers. So just looking in the literature, that I just saw that a lot of elements, the biomarkers such as the P53, P27, P21, as well as the COX-2, which is an inhibitor of the cell cycle protein, also the angiogenesis markers, VEGF, microvessel density, CD34, 31, and the hypoxia-inducible factor 1 alpha, and also different subgroups of the MMPs, and the Ki67 and the topoisomerases as a part of the proliferative markers, galactin-3, PTDG, pituitary tumor transforming gene, microarray, as well as pituitary stem cells, microenvironmental changes, inflammation, and the tumor, and lastly, the tumor heterogeneity has been dwelt a little bit in the literature. So this paper just came up in year 2012, and the last one, that has been the microRNA. The use of the microRNA has been reviewed by the Antonio de Leva the last year, that there is seemingly a hope while defining a tumor's aggressiveness in terms of their ability to secrete the microRNAs. The other thing is, as I mentioned, the tumor heterogeneity. There's a linkage between some genetic problems, genetic syndromes with that of the coexistence of the pituitary adenomas. That was reviewed by the Marta Corbonitz, and also a perfect paper by the Sylvia Assa just discusses about the normal cytogenesis of the adenohypophyseal cells, that there are a lot of transcription factors just giving rise to the differentiation cytogenesis, cytodifferentiation of the normal pituitary, the cell formation. Again, the Zero just mentioned in his paper that was published for about 3 months ago that there's a correlation, straightforward correlation between the PIT1, that of the GH-producing adenomas, PIT1 and the GATA2, with that of the TSH adenomas, and TPIT with that of the ACTH producing adenomas, and also the adenomas that has the ability to produce and proliferate the FSH and LH by the SF1 and the GATA2. Again, this in the same paper, this is to show you that the pituitary adenomas might be a part of a multiple endocrine neoplasia type 1 and as a part of the familial isolated pituitary adenoma, and the carne complex. There should be a systematic approach while just clarifying what the issue is. So if we just go back and try to find out what has been offered by the relevant the oncogenic research and TSH, tumor suppressor genes, and the transcription factor, there is a small place for them to be located in the pituitary tumor genesis. So we need some other extra the studies to shed on in order to shed light on that particular area. As I have mentioned you, I mentioned 3 times at least the use of the Ki-67 and the P53 as the WHO classification offers or recommends us while defining the atypicality from the typical adenomas is the Ki-67 and the P53. It is not an easy issue because their end results or their findings might change from laboratory to laboratory. This is what we call as a difference of the inter-laboratory evaluation. And this is even more complex because T53 expressivity, how to count them, how to stain them is still seems to be a problem, although it is widely recommended by the WHO. So the use of the biomarkers is not just fully justified nowadays. The predicting the invasive adenomas for the time being just is with unconvincing results. So biomarkers, biological markers, or the biomarkers of the aggressive manner of the pituitary adenomas have been investigated very extensively, but none of them widely accepted as being responsible for the invasiveness. The reason for that is very easy. We have a lot of question marks about the pituitary tumor genesis and their progression and their invasion from the point of the general pathology. A few words about the pituitary carcinomas. Again, 2 perfect papers, which is written by the Beatriz Lopez, 2005, and by Scheitauer, my mentor in the Mayo Clinic, which was written by in year 2006. Just make a compilation of the tumors that they have in their hand and what is being written in the literature. That the pituitary carcinomas are the tumors, pituitary tumors. They're exhibiting cerebrospinal and/or systemic metastasis. You cannot diagnose a pituitary carcinoma just looking how it looks like under the microscope. So we need their clinical, the aggressivity plus the clinical data. They are rare. They are just form only 0.1 to 0.2% of all pituitary tumors, and we do not know how to call a pituitary lesion if it shows an extensive infiltration of the brain. Most are ACTH positive, PRL, or the TSH secreting tumors, GH positive, just a few cases that has the ability to release the gonadotropin releasing the endocrine markers. They either arise from the invasive relapsing adenomas, that's the common pathway, or rarely they originate from the inactive adenomas. This cartoon comes from the Shlomo Melmet's the paper, and this shows the differentiation of a pituitary tumor originating from the normal pituitary adenoma, then the aggressive, and lastly, pituitary carcinoma with the metastases. Or the second alternative pathway could be from normal pituitary up to the pituitary carcinoma with the metastases. We still do not know how these pathways really work. Again, morphologically or ultrastructurally, pituitary carcinomas are not distinct from the atypical adenomas. That is to say that you cannot rely on the morphology. From the point of their biomarkers, they show a high Ki-67 label index, an extensive P53 protein, and also a lower expressivity both in the primary tumor and its metastases in the pituitary carcinomas. That is the scheme taken from the Kemal Tapar's book. This is the cutoff level that is for the Ki-67 labeling index. That's 3%. By the normal autopsy, pituitary, the gland, we do see a just small percentage of the cells that have the ability to proliferate and with the expressivity of the Ki-67. In the non-invasive adenoma, this might go up to 3%. And invasive adenomas, you can see a large spectrum, which is more or less just concentrated on the left hand. In the pituitary carcinoma, you might not even be seeing a proliferative cell, but this might go up to 24% of the cases, 24% in terms of the labeling index. Their prognosis is poor. The patients, 80% of the patients die within a period of 8 years. The rare patients with the term long-term survival has been written in the literature. So from the point of their survival, the carcinoma just act very aggressively and it kills the patients, and they are radio-resistant. And there are two perfect the articles about in relation with the pituitary cases, the problems in the relation with their diagnosis and with their treatment and the biologic behavior, which is being written by Dr. Sav. This has been written, this is his last paper published in August this year. This just comes from the end of the 2014, and how to use the different techniques, the different tools while differentiating the pituitary adenomas. So by conclusion, we have the pituitary adenomas, pathological, radiological, and clinical behavior. And SU classification is just a little bit behind the scene. It only defines the typical and atypical adenomas. In the atypical adenomas, there are two parameters. One is the Ki-67 labeling index. That should be more than 3%, and or the extensive P53 immunoreactivity. And in invasive adenoma, there should be signs in terms of the radiological or pathological sciences to the cavernous sinuses, bone, and nasal mucosa. The use of the biomarkers for the time being has a limited space in foreseeing their prognosis, and specific histotypes act destructively, as I've mentioned you, Crookes, silent or null cells, and pituitary carcinomas are the tumors, which is quite rare, and they should be disseminating in case of the cerebrospinal, the systemic metastases. They should be showing higher Ki-67 and P53 protein, and they are in general resistant to the radiotherapy. This is the contributors list. Fabio, Antonio, Cosumano, and Dr. Kovac, originally from the University of Toronto. Ciro is originally from the Columbia Medellin. These are the guys. Dr. Kovac is now 91 years old. Dr. Ciro, the neurosurgeon, and Fabio, our close friend. I would like to show you that we are just come together in a meeting in the year 2011 in the Santorini, and in the 12th International Pituitary Pathology meeting that we will be meeting next year in Lyons. Thank you for your attention.